Yes, ma'am, we are good to go.
Okay. Good evening, everyone, and welcome to the 25th series of ISPAE ACES Academics and Clinical Education series. This time, the theme is on skeletal dysplasia. And like every time, we have two case presentation and two talks by the expert. May I now please invite Dr. Ahila to proceed further. Ma'am.
Good evening, friends. Welcome to this 25th edition of ISPAE ACES. And it's a great honor to have Professor Ofaya and Dr. Mamta Muranjan here for this program as experts for the talk. And we have two senior pediatric endocrinologists from India, Professor Rakesh Kumar and Professor Riaz, as the moderator for the two case presentation. And it's an honor to introduce Professor Rakesh Kumar. He's the Professor of Pediatric Endocrinology at the Postgraduate Institute at Chandigarh, and he is the current Secretary of the Indian Society for Pediatric and Adolescent Endocrinology and the Executive Editor and one of the key players in establishing the Journal of Pediatric Endocrinology and Diabetes. And he has special interest in childhood diabetes, has several awards to his credit, including the Commonwealth Academic Fellowship, the ISPAE's Alan Rash Fellowship, and he's a fellow of the Royal College. And he has several publications and book chapters to his credit. Welcome, Rakesh, and I welcome you to take this program ahead. Thank you so much. All the best.
Thank you, Dr. Ahila, for that kind invitation and introduction. So, as I already outlined, we'll be presenting first case, which is to be presented by Dr. Virali Solanki, who is a trainee fellow at Mumbai. Should we start with the presentation, Dr. Virali? You can start sharing your screen. So this case is about a 6-year-old child, actually, who presented with a ricket-like phenotype, and later on came out to be an interesting case of a rickets mimic, which she will be revealing what the mimic was. Okay, so let's start with the case presentation.
Good evening, everyone. So today we are here. I'm Dr. Virali Solanki, a secondary NP resident of Pediatric, Kokilabin Hospital, Mumbai. So today we are here to discuss an interesting case of rickets mimic. So we had a 6-year-old boy hailing from rural Maharashtra presented to us with complaint of progressive limb deformity since the age of 2 years. Parents also noticed short stature since 2 years of age. The child had no fractures, trauma, hypocalcemic seizure, or tetany. The child had no history of polyuria, polydipsia, recurrent diarrhea. He had history of delayed dentation. Dentation started after 14 months. He has been, for these symptoms, he has been administered vitamin D therapy on multiple occasions, but the limb deformity was not responded to it. Birth history was uneventful. He has born of a non-consanguineous marriage. Father was also short without any limb deformities. He had a younger sister. She is alive and well. Developmental milestone wise, he had started walking at the age of 14 months. Walking was delayed. Other milestones were achieved at appropriate ages. Examination findings, the child's vitals were normal on presentation. His weight was 12.5 kg, which was minus 2.7 standard deviation, and height was 88 centimeter, which was minus 5.06 standard deviation. BMI was normal. Upper segment, lower segment ratio was 1.4, which was increased for the age. The child had generalized hypotonia. Anterior fontanelle was closed. The child had relative macrocephaly, but no obvious facial dysmorphism. He had rhizomelia with brachydactyly, trident hand, with bilateral wrist, knee, and ankle joint widening. He has pectus excavatum also, and in lower lip, windswept deformity, as we can see in picture. One limb was having genu valgum and one was having genu varum. So from our history and examination finding, our clinical differential diagnosis was either it could be a vitamin D refractory rickets, like hypophosphatemic rickets, vitamin D dependent rickets, or renal rickets. or it could be a skeletal dysplasia, which was mimicking the rickets. So we have done some biochemical investigation in which we found that serum calcium was normal, serum phosphorus was normal, serum alkaline phosphatase was normal, serum parathyroid hormone was normal, serum vitamin D was insufficient, which was 18.7 nanogram per ml. Though it was low, our normal serum phosphorus and normal serum alkaline phosphatase rules out the rickets. So we have done bilateral hand and wrist AP X-ray, and in which we found that the child has curved metaphysis, dysplastic epiphysis, dysplastic carpal bone, and short and broad phalanges. We compared this X-ray finding to the child with rickets, in which we can see the cupping and fraying of the metaphysis, but in rickets, no epiphyseal dysplastic changes would be there. So we performed the skeletal survey for the child, and in the skull lateral X-ray, there was a relatively large cranial vault with small skull base. On the X-ray spine lateral view, there was a platyspondyle and antiopic of vertebrae. On X-ray pelvis and lower limb AP view, there was a dysplastic acetabulum with dysplastic epiphysis and medial peaking of femur. So to classify, as our child's spine was involved, epiphysis was involved more than metaphysis. To combining both, child was having spondyloepiphyseal dysplasia. We found some similar paternal phenotype in father also. Father was having borderline. Father was also short, borderline short with height of 161 centimeter, which was on 3rd centile. As we can see in the picture, the father's upper limb was just barely touching the pelvis. So he had some short stature only. No facial dysmorphism. He had relative macrocephaly. As we can see in the picture, the father also had similar trident hairs as the child, along with brachydactyly. We have performed father's skeletal survey, in which there were some residual changes of the skeletal dysplasia. As we can see in the bilateral hand X-ray, there was short and broad phalanges and metacarpal bones. Femoral neck was short with flattened femoral head, and in spine X-ray there was mild anterior wedging of vertebrae, but no platyspondyle. So to summarize our clinical findings, in which we had a 6-year-old boy with some progressive limb deformity, with short stature, which was not responded to oral vitamin D therapy, with biochemistry being normal. Similar family history in father, similar family history in father, likely to be autosomal inheritance pattern, and X-ray changes, which was suggestive of spondyloepiphyseal dysplasia. Our clinical diagnosis was pseudoachondroplasia. So we further done the genetic analysis using clinical exome sequencing for pseudoachondroplasia and related genes, in which it was found to have heterozygous mutation in the COMP gene. With this gene implicated into the pseudoachondroplasia and multiple epiphyseal dysplasia. However, in our child, the spine was also involved. Hence, we can say it was fitting into the pseudoachondroplasia. Though the variant was reported as variant of uncertain significance, looking at the clinical picture, it was fitting in the pseudoachondroplasia. In silico prediction also, this mutation was damaging. So to further confirm our diagnosis, it can be a novel mutation, which we can confirm with the parental testing. So we started on the oral calcium and vitamin D supplementation for our child, and physiotherapy was initiated. Pediatric orthopedic review was taken. They have advised some surgical correction and performed right medial and left lateral hemiepiphysiodesis. 3 months after the surgery, we have done the X-ray, in which we can see the remarkable improvement in the limb deformity. At last follow, the child was 9 years of age with limb deformities and gait was improved, but bilateral genu varum was persistent. His weight was 16.8 kg, which was minus 2.7 standard deviation. Height was 98.6 centimeter, which was still short, which was still minus 5.4 standard deviation. His height velocity was 3.4 centimeter per year, and BMI was normal. He was pre-pubertal and compliant to vitamin D and calcium supplementation. So coming to the discussion of skeletal dysplasia, if we are suspecting a child to have skeletal dysplasia, we should perform the skeletal survey constituting the skull X-ray, bilateral hand and wrist AP X-ray, thoracolumbar spine X-ray, and lumbosacral spine X-ray, and femur to ankle AP view X-ray. In X-ray, if the spine is involved, first we should look for the spine. If spine is involved in extremities, only epiphysis is abnormal. The possible condition would be spondyloepiphyseal dysplasia congenita, spondyloepiphyseal dysplasia tarda, pseudoachondroplasia, or NIST dysplasia. If spine is involved along with metaphysis and epiphysis, both, the possible diagnosis can be spondyloepiphyseal metaphyseal dysplasia like Morocco syndrome or metatropic dysplasia. If spine is paired and only in extremities only epiphysis is abnormal, we can predict it could be a chondrodysplasia punctata or multiple epiphyseal dysplasia. If only metaphysis is abnormal, it could be a achondroplasia, hypochondroplasia, short-lived polydactyly, or metaphyseal dysplasia. So what is pseudoachondroplasia? Pseudoachondroplasia is an autosomal inherited disorder, bone disorder, which is caused by mutation in the COMP gene. The age of presentation could be 9 months to 2 years of age, and it's characterized by short limb, short stature, limb deformities, waddling gait, intelligence, facial feature, and head size are usually normal. What is pseudo about the pseudoachondroplasia? As we can see in the picture, achondroplasia and pseudoachondroplasia both will have normal trunk, short limbs, rhizomelia, and their head size would appear large. But achondroplasia body disproportion would present at birth, whereas in pseudoachondroplasia it will be of later onset. The achondroplasia will have true macrocephaly, whereas in pseudoachondroplasia there will be a relative macrocephaly. Means this pseudoachondroplasia will appear to be large, but if we measure the head circumference for the same, it will be normal for the age. In radiology, as we can see, in achondroplasia, there will be a trident acetabulum, narrowing of interpedicular distance of LS spine. Whereas, as we had discussed in our case, there will be a metaphyseal and epiphyseal irregularity along with beaking of spine. The gene for achondroplasia would be FGFR3 gene and pseudoachondroplasia COMP gene. So what will be the prognosis for pseudoachondroplasia? They can have atlantoaxial instability due to odontoid hypoplasia. They can have risk of premature osteoarthritis. The range of motion will be limited at the elbows and hips. They may have short stature. Average adult male height would be 120 centimeter, and average adult female height would be can be 116 centimeter. Which are the other conditions which can mimic the rickets? So one most common condition which can come with the similar limb deformity like Januvarum, bow legs, and age of presentation would be same as infancy and adolescence. They also might have short stature, but differentiating point would be Blount's disease more commonly will be seen in overweight children. Biochemistry would be normal in Blount's. In radiology, as we can see, classical beaking of medial proximal tibia, and distal femur. Some cases distal femur also we can see. And in Blount's, there will be no response to oral calcium and vitamin D supplements. Another condition which can mimic the rickets is Schmidt metaphyseal dysplasia. The Schmidt metaphyseal dysplasia also will present in late infancy with bow legs, short stature, and waddling gait. The X-ray changes of the Schmidt metaphyseal dysplasia would be similar as rickets, like metaphyseal cupping, splaying, and fraying. But the differential point would be in Schmidt, lower limb would be more affected than the upper limb. Biochemical test, if we do, it will be normal. In radiology, coxa vera will be there, and osteopenia won't be there in Schmidt. Another possibility, osteogenesis imperfecta in the milder version can present as rickets, like with short stature, bowing of long bones. Radiology will show osteopenia, but OI osteopenia would be much more greater than rickets. They also can have delayed dentition. What will be the differentiating point? So the OI child will have positive family history, can have systemic symptoms like blue sclera, hearing loss, and congenital heart disease. Kyphoscoliosis they can have. On radiology, if osteopenia child can have multiple fracture at different stages of healing. Another rare condition which can mimic the rickets is hypophosphatasia in the late form. They can also have short limb, short stature, delayed walking, gait with knock knees. Hypophosphatasia child can have bowed arm and legs. Radiology will be similar changes at the growth plate like wide irregular metaphysis. But the differentiating point would be radiolution metaphyseal tongue, as we can see in the picture. And if we do the biochemistry of hypophosphatasia, they will have decreased or absent alkaline phosphatase activity and hypercalcemia with hypercalciuria. To summarize our learning point from this case, so if we are suspecting a diagnosis of rickets in a child, it should always be supported by the biochemical abnormalities like low phosphorus and high alkaline phosphate and radiological changes. If the biochemistry is normal and radiographs are not typical, think of other causes. And if we are suspecting the skeletal dysplasia in a child, the skeletal survey must be performed to look the changes in spine, epiphysis, and metaphysis. So we can classify the skeletal dysplasia like this. And early recognition and intervention in any kind of skeletal dysplasia will improve the life. Thank you.
Thank you, Dr. Virali. So start with the discussion. So there are a few questions in the chat. Some questions coming all the way from Pakistan, and looks like Indian audience is busy with either with the cricket match or so. So we have three questions from the audience. So one is regarding how long to give calcium and vitamin D. I'm not sure in which particular condition they are asking about. I presume they are asking about vitamin D deficiency rickets. It could be sometimes calcium or nutritional low intake of calcium causing rickets as well, particularly in infants. So vitamin D in obviously doses would be different for infants and toddlers and adolescents. So there are the different doses and different regimens which we follow. For infants, we would be actually not giving TROS therapy. So we would be giving daily vitamin D 2000 units usually, which is given over say 6 to 12 weeks at least. And calcium has to be supplemented, say at least 50 to say 100 milligram per kg per day,
Rakesh,
along with the calcium. Yeah, yes, Dr. Hela.
They've just mentioned that they are asking about vitamin D in pseudoachondroplasia.
All right. So vitamin D deficiency, if documented in pseudoachondroplasia, the treatment would be similar as for any normal child with vitamin D deficiency. Okay. So next question is about indication of any growth hormone in this particular child to improve height. So whatever little experience we have, so people have actually given growth hormone for children with various types of skeletal dysplasia, including achondroplasia and hypo or pseudoachondroplasia, but the height improvement has not been significant. So there is, obviously this is not an approved indication for growth hormone therapy. So, okay. Is there any role of vitamin D and calcium in skeletal dysplasia? Yes, we have to maintain normal calcium and vitamin D, particularly in these children with skeletal dysplasia. So we should be looking after the bone health, obviously, in these children as well, and maintain normal levels of vitamin D as far as possible. So with any other queries, if we have? So Dr. Zalak has asked about any trial with vosoritide in pseudoachondroplasia. I am not aware of. It is obviously approved for achondroplasia, but I'm not sure about pseudoachondroplasia.
If I can just answer that, and this is Professor
Yes,
Ophir.
please. Yes, please,
It's-
Professor Amaka. Yeah.
Please don't be confused by the fact that they both have achondroplasia in the name. They're not the same. The genes are completely different. So vosoritide actually acts on FGFR3 pathway. So I cannot see that vosoritide would be used for pseudoachondroplasia, which is a comp mutation.
Yeah. Okay. Thank you. Okay. If there are no other questions,
How do we differentiate with hypochondroplasia?
yeah, Dr. Virali, you want to answer that?
Yes, pardon.
Hypochondroplasia.
The difference between pseudo and hypochondroplasia, that's what you are asking, Dr.
How
Zalak?
do we, yes, how do we detect?
Hello.
Yeah, Dr. Virali, if you want to answer.
Pardon, sir. Hello.
Okay.
Pseudoachondroplasia is its own comp. Hypochondroplasia and achondroplasia are FGFR3 mutations. The features in achondroplasia are more severe than in hypochondroplasia. So, for example, if you take the spine, an AP spine radiograph, you expect to see in normals, and I will show that in my talk, you expect to see widening of the interpedicular distance of the lumbar spine as you go down from L1 to L5. In achondroplasia, rather than widening, as you go down from L1 to L5, it actually reduces. And in hypochondroplasia, it stays more or less the same. So that's just one example. The bullet-shaped platyspondyly that you see in achondroplasia, you may not see at all in hypochondroplasia. The degree of shortening, rhizomelic shortening, is not as severe. I suppose the best way for you to think about hypochondroplasia, hypo meaning less, it's less than achondroplasia. Pseudoachondroplasia is an epiphyseal dysplasia, as we've just seen, and really the radiographic differences are quite distinct. It's easier to describe when you're looking at the radiographs at the same time. Thank you.
Thank you, ma'am.
So, yeah, thank you, Professor Amaka. So if you could also answer, so which of these two would be more likely to mimic rickets?
Are you asking me?
Yeah, if you could add that as well.
I would say that
two would, yeah.
None of them mimic rickets radiographically at all. Biochemically, you may have both. You may have rickets and achondroplasia, or rickets and pseudoachondroplasia, but radiographically they are not. You would not mix them up at all. I think hypophosphatasia is the closest amongst the things that we talked about. Metaphyseal chondrodysplasia type Schmidt is a strong differential, but again, they have normal biochemistry, they have normal radiographic bone density.
However, both could have clinically bowing of legs and features looking like rickets. Clinically,
exactly.
Obviously, yeah.
Exactly. So clinically, the hypochondroplasia would be the most likely of the three of those conditions to look like rickets.
Rickets. All right.
Yes,
Yeah.
they don't usually have the same degree of facial dysmorphism as the achondroplasia.
So we have some more questions. So I think these questions are not very much related to the discussion, but still we could take them up because there are no other questions and we have a few minutes left. So is there any role of growth hormone combined with GnRH analogs in this disease? I would say this is a bit of extending our view and more of imagination, I would say. So we don't have a clear-cut role of GH to begin with. And I just can't think of adding GH and GnRH analog combined to help them for the height. Particularly in Indian settings, so the indications where we are not sure, will there be any benefit for giving growth hormone therapy, we would usually not be offering, particularly when growth hormone is not approved for that particular indication. Okay. So any more inputs from the panelists? Otherwise, we could move ahead.
So,
And
Dr. Rakesh, may I just
yeah,
add,
Dr. Mamta, yeah, please.
since the discussion was on growth hormone, I think we can very clearly say that the only indication for growth hormone in the skeletal dysplasia is when there is short stature related to Shock's deficiency.
Yeah. Yeah.
You know, the Lerry-Wheel and Turner syndrome. But apart from that, there is no role for growth hormone or any other analog of in skeletal dysplasias.
Exactly. Yeah, so Shock's gene mutation, yeah, would be theoretically classified obviously as a skeletal dysplasia. Yeah, and that's the only approved indication for growth hormone. That's right. All right, so I think we have expert amongst us, and I think.
And we go on to the next case presentation. Before that, I take this opportunity to invite Professor Riaz, who's the Associate Professor of Pediatrics at Idukki Medical College. And he's the co-author of the ISPAE National Guidelines on Congenital Hypothyroidism. He has several publications in peer-reviewed journals in several chapters. And he's a part of the state team, which has established comprehensive care clinics for the whole state of Kerala for patients with type 1 diabetes with their MITHI program. Riaz, it's an honor to have you here and welcome aboard. Please take the proceedings further. Thank you so much.
Thank you, ma'am. And thanks for this opportunity from the ISPAE team. And like the interesting case which we discussed, which came as a case of rickets and then proved something else. So Dr. Lakshmi Deepika, who is an endocrine fellow at Indira Gandhi Institute of Child Health at Bangalore, is going to come with another interesting case where a 10-year-old child came with some bony deformities and short stature, and I'm inviting her to present the case. Over to Lakshmi.
Thank you, sir. Good afternoon, everyone. Shall I start sharing, ma'am?
Yes, please.
Okay. Are my slides visible, sir?
Yes, yes, yes. Can you make it PowerPoint?
Yeah.
Oh, right.
It's okay, sir?
Yeah,
Right.
Thank you.
Okay. So, good evening, everyone. Today, I'll be presenting a rare case of fragile bones. So, I thank Dr. Riaz for his inputs and his support. And I'm a clinical fellow, as mentioned earlier. So, I'll be starting my case now. So, my patient is a 10-year-old girl child who came with complaints of deformity in the upper back for 2 years, which was insidious in onset, gradually progressive, and developed a hump in the upper back. And back pain for 1 year, which was more over the lower back, which is also insidious in onset, progressively increasing in severity, non-radiating pain, relieved temporarily with rest, and increases with activity like bending, lifting heavy objects, so much so that the child was unable to carry school bag also after a period. And it was not associated with any morning stiffness. Coming to history of presenting illness, there's no history of fever or cough, no history of delayed dentition or dental or gum problems, no bowel and bladder disturbances, no radiating pains or joint pains, no weight loss, loss of appetite, or night sweats, no weakness in limbs or gait abnormalities, no visual disturbances, hearing problems, or any loss of sensation. Coming to past history, she had 3 fractures in the past, 2 of the forearm and 1 of the femur, all following trivial trauma between ages 4 and 6. Currently, the child is 10 years old. And 5 months back, like before presenting to us when she was 9 years, she was evaluated for this back pain complaints. And that time when blood tests were done, the calcium profile was normal except for low vitamin D and mildly elevated ALP of 541. Then at that point, there were X-rays also done because of her back pain. But nothing was commented about the X-rays at that time. Upon reviewing the X-rays, when we reviewed the X-rays, we seen mild kyphosis along with osteopenic changes and also vertebral compression fractures. So this child, based on the biochemical evaluation, was diagnosed as vitamin D deficiency, and she was started on calciferol sachets for 6 weeks along with calcium supplements. She completed the course of 6 weeks but has seen no improvement. Hence, she was brought by parents to here for persisting complaints. Coming to family history and birth history, we wanted to know the family history, if any affected family members are there or the parents are affected, anything like that. But this child was adopted in the newborn period and no birth records or family history of biological parents was available. And mother says that she has attained age-appropriate milestones and currently child is in 5th standard with good scholastic performance. At the end of my history, my differentials would be osteogenesis imperfecta, juvenile idiopathic osteoporosis, and vitamin D deficiency or Langerhans histiocytosis. Coming to examination, upon head-to-toe examination, there was a bony prominence on the forehead, which mother specifically told that it was not there before and it has started recently. And there's no blue sclera. Cubitus varus deformities of bilateral upper limbs was there. No lower limb deformity. There is kyphoscoliosis of the back. And there is an irregular hyperpigmented patch over the back, which was not crossing the midline. It's a café au lait patch. Coming to her anthropometry, her weight and height both are between 3rd and the 10th centile. Arm span is normal. Body proportions are also normal. Her BMI and BSA is okay. So this is her growth chart. Her bone age is 9 years. Chronological age is 10 years. So no much delay or delayed bone age or anything here. Her weight age is 7.5 years and height age is 8.5 years. Coming to a systemic examination, it was normal along with the cranial nerve examinations and everything. And there's no organomegaly also per abdomen wise. And her SMR is B1, P1, A1. So differential diagnosis after examination would be osteogenesis imperfecta, juvenile idiopathic osteoporosis, vitamin D deficiency, or Langerhans histiocytosis. So then we have evaluated her biochemically. Her CBC was normal. Calcium profile was normal except for mildly elevated ALP and a low vitamin D. PTH was normal. Renal function test and liver function test were normal. Her thyroid profile was also normal. Coming to her X-rays, her skull X-ray showed a typical ring-shaped sclerotic lesions, multiple lesions. The place where the bony prominence was there also showed a sclerotic lesion, and even the other areas there are multiple sclerotic lesions. And there's a particular area where it is ring-shaped and there is a lytic center. Coming to her spine X-ray, compared to her previous spine X-rays which were done outside, there is a more severe kyphosis and osteopenia is observed throughout with multiple compression fractures. This was a DEXA scan which showed a Z-score of minus 8.8, severe osteoporosis. On bone scans, there's abnormal osteoblastic changes at multiple sites, and also bone scan suggested an increased tracer uptake in bilateral humerus, forearm bones, and bilateral tibia. PET-CT was suggested to rule out Langerhans histiocytosis. Coming to PET-CT, a diffuse osteoporosis with multiple sclerotic skeletal lesions was seen. There's no abnormal, enhancing, or metabolically active lesions that are suggestive of primary neoplasms, no significant lymphadenopathy or organomegaly. And the PET scan gave a possibility of metabolic bone disease or skeletal dystrophy, ruling out primary neoplasms. So then we went ahead and did a molecular analysis for this child, clinical exome sequencing, which showed a mutation in SGMS2 gene, which encodes for sphingomyelin synthase, which produces sphingomyelin, a major lipid component, which plays a role in the bone mineralization. So that was an autosomal dominant disorder that led to an autosomal dominant disorder called Calvarial donut lesion with bone fragility with or without spondyloepiphyseal dysplasia. So these lesions, the ring-shaped lesions which we have seen, are called Calvarial donut lesions. So there are 2 lesions on the skull like that. Coming to summary, a 10-year-old adopted girl with history of recurrent fractures came with complaints of low back pain and deformities. On examination, she had a bony prominence on the forehead, bilateral cubus varus deformity, kyphoscoliosis, and cafe-au-lait patch over the back. Radiograph showed diffuse osteoporosis with ring-shaped sclerotic lesions of skull and multiple compression fractures of vertebrae. PET scan pointed towards metabolic bone disease or skeletal dystrophy. DEXA gave a Z-score of -8.8, severe osteoporosis, and bone scan gave an abnormal osteoblastic activity. Genetic analysis revealed mutation in SGMS2 gene responsible for an autosomal dominant skeletal disorders, which is very rare. It's called the Calvarial donut lesion with bone fragility. So coming to management, the child started on maintenance doses of calcium and vitamin D supplements, and she was given first dose of zoledronic acid infusion at 0.025 mg per kg per dose. And a 6-monthly zoledronic acid infusion is planned for this child, now increasing the dose up to 0.05 mg per kg per dose for her second visits and the consecutive visits. And an annual cranial nerve examination at each visit is planned, along with an yearly DEXA to see the improvement and a lifelong maintenance doses of calcium and vitamin D supplements. Here, the cranial nerve examination at each visit is planned because this disorder, because of the sclerosis in the skull, it is known to narrow the foramens where the cranial nerves exit, and it might cause cranial nerve palsies. So the importance of doing a cranial nerve examination at each visit. Along with that, because of the zoledronic acid infusions we are planning for her, the sclerosis will increase with the treatment as such. So the cranial nerve examination is crucial here. Coming to the skeletal disorder as such, Calvarial donut lesion with bone fragility is a rare autosomal dominant skeletal disorder. It has a poor bone mineral density and multiple fractures, especially of vertebrae, and typical sclerotic donut-shaped lesions in the cranial bones. It is associated with various mutations in SGMS2 gene. So far, less than 100 cases have been reported worldwide, with wide phenotypic variability among the affected individuals. And most of these individuals are within the same family, that each family has many affected individuals. Owing to the autosomal dominant pattern, there is a wide variability as well in the phenotype. Very recently, a novel IFITM5 missense mutation has been identified in a Japanese patient with this rare disorder. Coming to a few case reports, all the case reports are from other countries. There was no case report from India as such. In 1988 itself, Obe et al. Described 12 family members of a single family showing this disorder, donut lesions of the skull, pathological fractures, and a typical bone-in-bone vertebral bodies. This bone-in-bone in the vertebral bodies is seen in this family members only, and it was not reported in other cases. So it was almost exclusive to this family members. It showed a nonsense variant mutation in SGMS2 gene. And in 2009, Jackal et al. Published 3 members of same Finnish family who had vertebral and peripheral fractures and same donut lesions in the skull. These patients also had cranial nerve palsies. 2 out of the 3 patients had cranial nerve palsies. And recently in 2019, 2 patients from Dutch family and 1 Hispanic patient showed low bone mineral density, multiple childhood onset peripheral and vertebral fractures with no donut lesions. So donut lesions is not always present in all these patients. Also, these patients, all 3 have shown facial nerve palsies. 2 of them have shown neurological symptoms like diplopia, sensory neuropathy, ataxia, and absent reflexes. In most of these case reports, facial nerve palsy is the most common cranial nerve palsy reported. Then Shua et al. Recently in 2021 reported 3 new patients from same French-Canadian family, Aube described. So the 1988, 12 members of the French-Canadian family were reported, and in the same family, 3 new patients were reported in 2021. Even these patients had the same typical bone in the vertebral bodies, not seen in any other family. Along with that, same pathological fractures and donut lesions. And the mutation is same, SGM-S2 mutation. And a Japanese patient in 2021 was reported with the same features, and the mutation was a missense mutation. And in 2023, 11 members of Russian family also reported osteopenia, donut lesions, and pathological fractures, and a mutation in SGM-S2 gene. All these cases are not from, none of the cases are not from India. And this, to my knowledge, this is the first case in India. And we would love to do the genetic analysis for the parents. That was the first thing we thought of. But then since she was adopted, there was no way to know if the parents were affected or not. So, thank you.
Thank you, Dr. Lakshmi Deepika. It was a very interesting case. And now there is more information regarding osteoporosis in children, apart from osteogenesis imperfecta. But in many cases, it is difficult to find out the actual diagnosis. And we end up in a basket diagnosis of idiopathic juvenile osteoporosis. But this case has a typical calvarial swelling, which led into more detailed evaluation, and ultimately genetic test has helped in catching the diagnosis. And we have Mamda ma'am here. I would like ma'am to give a comment on this case, because it's a very interesting and very rare case. Mamda ma'am, please.
Thank you, Dr. Riaz. It is extremely rare. We saw just barely, less than 50 cases worldwide. Personally, I have not come across this child. And I was a little intrigued looking at the cafe spot and wondering whether this could be a polycystic, yes, dysplasia. So very, very interesting. And the good thing is that it is treatable and the patients improve with bisphosphonates.
And Prof, off your head, can I just add? Yes, very interesting case and very well presented. But I will say, as a radiologist and as somebody who tries to limit radiation dose, everybody should remember that skull radiograph, because it's a characteristic. It's seeing an elephant's trunk, right? Once you see that, you don't need to do anything else. I mean, you can do the genetics if you want, but you don't need to be doing the PET scan or all of these other tests. That there's nothing else that gives you those donuts, the Calvarial donut sign. And by coincidence, I saw one just 2 weeks ago here in Sheffield. Even though they're rare, when a rare thing comes up, it seems to come up more than once at the same time. Thank you. I really enjoyed the presentation.
Thank you, ma'am.
Thank you very much. Lakshmi, I just have a question. I always thought you had talked about the other mutation, the ITM5, but I thought that's a mutation that causes osteogenesis imperfecta type 5. And you had mentioned that the Japanese group had mentioned the Calvarial donut lesions.
Yes,
the similar mutations. I always associated it with OI5.
Yes, ma'am.
I mean, it's just an offhand comment, I think. But, thank you so much, Lakshmi. That was a beautiful presentation.
Thank you, ma'am.
Over to Ahilya, ma'am.
Thank you for such a wonderful lecture, Dr. Muranjan, madam. It was absolutely fascinating and was a real journey into the genetics of skeletal dysplasia. And I think you really helped us understand, because most of the time, as Riya said, we are lost for words and lost for investigations also. Thank you so much. And it's been such a wonderful session today. And
Ma'am, one question about oct'23 is there. So it's regarding any trial going on in India as well as availability in India. Ma'am.
So there is no ongoing trial in India, though this drug is available and indicated in Europe for children with achondroplasia more than 2 years, in USA, children more than 5 years. And as of now, it is not available. In fact, in one of our rare disease committee meetings, there was a debate on whether the drug is actually, of much benefit. The height gain is about on an average 1.6 centimeters per year. So as of now, it's not available in India.
Okay, ma'am. Thank you.
two absolutely fascinating lectures from Professor Ofaya and Professor Muranjan, madam. Now I invite Zalak to tell the vote of thanks, please.
Thank you so much.
Thank you, Riaz and Rakesh, for the wonderful moderations.
Thank you, ma'am.
So on
Thank you.
behalf of team ISPAE, led by Dr. Ahila, I would like to thank you all for joining today our ISPAE ACES Series 25 on skeletal dysplasia. We won the match. Congratulations. India won it. I also thank the experts, Professor Amaka Ofia and Dr. Mamta Muranjan. A special mention for Dr. Abhishek Kulkarni, so that I could reach to Dr. Mamta Muranjan. Thank you. Thank you to the moderators, Dr. Rakesh Kumar and Dr. Riaz, for leading the discussion so well. And thank you both the presenters, Dr. Virali and Dr. Lakshmi, for the wonderful case presentations. Thank you, RX team, for managing this so well. Thank you, everyone. Good night. The next ISPAE ACES will be in December, and we'll declare the details soon. Thank you so much.
Thank you
everyone.
and good night.
Thank you, ma'am.
Thank you
Good
very
night.
much.
Good
Thank
night.
you.
Thank you. Thank you.
Thank you. Thank you.